Thanks very much. So we're going to move from the third space back to the second space. I never knew it was called that when we talk about biliary endoscopy, but there we are. I've got two cases. Please stop me after the first, Mr. Chairman, if there's not time. But there are a couple of quick cases. So the first is a 68-year-old man with chronic calcific pancreatitis. He's been through our multidisciplinary meeting. He's got a dilated pancreatic duct, but he's not a candidate for surgery because he's got extensive portal hypertension due to portal vein thrombosis and intra-abdominal varices. But he now presents with jaundice and imaging. Imaging suggests a dilated bile duct, a dilated pancreatic duct, a probable low bile duct stricture, and they're not the best images, these, but a stone in the bile duct. So he went to his local hospital and had an ERCP. And the ERCP has felt that although he did have a little bit of a low bile duct stricture, this wasn't terribly important, and it is obstruction related to his stone. He had a sphincterotomy. He had an attempted balloon extraction, which was not successful. And so the mechanical lithotripsy was used. The endoscopists managed to engage the stone with the mechanical lithotripsy, close the lithotripsy basket, and it snapped. Okay, so the stone was so hard that it snapped, but these baskets are designed to break at the basket end. It didn't. It snapped at the handle end, and so the sheath was taken off, and the salvage lithotripsy was passed down over the wires, and this was cranked up like a medieval torture instrument, and that broke as well, again at the wires. And so now the endoscopist is faced with a patient with wires around a stone in the bile duct, and completely unclear as to what to do next. They spoke to us at the time, and what we advised is to, as was said earlier, keep calm, and to push the wires back down the endoscope and leave them curled in the duodenum, and transfer the patient to us to see if we could do anything further. Bearing in mind that although one might in other circumstances say, oh, well, speak to the surgeons, this had already been approached, and there really were very, very few surgical options here. Just as a little practice point, there's nothing to be gained in this situation by you occasionally get patients who have the bare wires sellotaped to the side of the mouth. That's awful for the patient and doesn't actually get you anywhere. The wires can be safely pushed down into the stomach or into the duodenum. Okay. This is a horrible picture, but essentially this is what they were left with. So the wires curled up here, and the basket around a stone in the bile duct. So the question is what to do next. Anybody got any clever ideas? We needed them. Mariana. ESWL. Okay. Yeah. Absolutely, that could be considered. One interesting point about this stone on the CT scan, and we do this now increasingly for pancreatic duct stones, is we, on a CT, we ask our radiologists to give us the Hounsfield units on the stone. And our experience, actually largely from the experience of our urology colleagues, is that if the stone has a Hounsfield unit of more than 1,000, it is very unlikely, again in the renal sphere, that they will break such a stone up with ESWL. We have, rightly or wrongly, taken that forward to the pancreaticobiliary sphere. And so this stone had a Hounsfield unit of 1,500. So it was a rock-hard stone. And in fact, it's a radio-opaque stone, which is just a little bit unusual. But there we are. So any other... So we didn't go for ESWL. Any other ideas? Dilation, okay, yeah, good point. Could we dilate up? It's not a huge stone. It's maybe, I don't know, 10 or 11 millimeters. I think that would be risky. The patient does have a low bile duct stricture. You would need to dilate that stricture up to at least 11 or 12 millimeters. We're not talking about a balloon sphincteroplasty here, so I think that would carry quite considerable risks. Helmut mentioned the option of cholangioscopy. And so that's what we did, just to orientate. How are we looking at it? So on the left is the endoscopic duodenal view. In the middle, you'll see the fluoroscopy, and on the right is the cholangioscopy view. First thing to say is that this is a very radiopaque stone with the basket stuck around it. But here we are on the right. We're starting to break this up. This stone was like a rock. One of the things as we were doing this, we thought this is interesting because bile duct stones are usually either orange, brown, black. This was a very white stone, which was, anyway, just an observation, but it's certainly something that we noticed. And so we eventually, you can see the ends of the basket coming into view here. And so after a good 45 minutes, and if I recall 2 or 3 EHL probes, we were able to clear the stones from the basket and then using standard grasping forceps remove the basket. Cholangiogram at the end showed a bit of a mess up in the bile duct there. We took out some fragments and we left a stent in, but there were still some stone fragments. And so we went back. What am I doing now? So he did well after that procedure, but we went back in a few weeks later to see if we could finish the job. And I won't bore you, but again, there's this stones now up in the common hepatic duct. But here's the interesting thing. I don't know if I can pause this. Probably not. But look at the pancreatogram here. Sorry, let me just see if I can. So this pancreatic duct is fistulating into the bile duct. And in fact, what you were seeing there was a very large, hard pancreatic stone that has fistulated through through the wall of the pancreatic duct into the bile duct above the low bile duct stricture. So we're in the bile duct here, and then we turn right, and you can see on this view that we can pass the cholangioscope or the pancreatoscope, I don't know what you call it in this position, into the pancreas, and rather unusually, it may not have had any direct relationship to the pathology, but as we pass the scope into the pancreatic duct, you can see here, we're well into the pancreatic duct here. And in fact, the patient had a main duct IPMN within the pancreatic duct, which at the same time we were able to biopsy and make the diagnosis. There was no evidence of malignancy, so I don't think this was a malignant fistula. I think it all just related to very large, hard pancreatic stones. Ongoing management was interesting, of course, because the patient had a low bile duct stricture, and yet we were concerned about putting in a fully covered metal stent here because we might well have obstructed the pancreatic duct in doing so because the pancreatic orifice itself was completely obstructed. So an unusual case, but I think that if one does get into the difficult position of a basket stuck around the stone, there are a number of options, but certainly cholangioscopy may be one of the ways out. Time for one more quick one, or do we need to move on?
Peter, one more?
Quick one, okay. And this links to the very nice case presentation, video case presentation earlier. 48-year-old man, bile duct stone, difficult biliary cannulation, and as we often do now, a 5 French unflanged pancreatic stent was put into the pancreatic duct to reduce the risk of pancreatitis, but also to aid cannulation. Still, cannulation was difficult, and so the endoscopist did a pre-cut sphincterotomy, and to his horror, in doing that, he managed to slice through the pigtail of the pancreatic stent. And you can imagine the scene that all that then is left is a tiny little end of the stent just sticking out of the pancreatic duct. They tried to grab it, and in doing so, they just pushed it into the pancreas. The patient then had 2 further ERCPs, and all that happened then was that they pushed the stent even further into the pancreas. Now, this patient had pain. He's a young man, and he was referred to see if we could do anything further. And so I'll just show you this quickly. Again, we reached for the cholangioscope, and one can see we're right out in towards the tail of the pancreas here, and here's this pancreatic stent bobbling around in the pancreatic duct. Now, there are now new spyglass snares and baskets which would have been ideal for this, but I did this a couple of years ago, and so all we could do was use the tiny spy bite biopsies to grab the end of the 5 French stent, and very, very, very carefully and slowly, but with a big cheer from the nursing staff at the end, we managed to pull this back out into the duodenum. Proximally migrated pancreatic stents are quite a new complication. We didn't really see them 10, 15 years ago, but now with a vogue to using them more for different indications, we are seeing this as more of a problem. These stents never migrate. They're always put there because, during deployment it accidentally gets pushed proximally. So thanks very much.
Dr. Webster, first, congratulations that you succeeded to Brexit all these stones from the second.
Please, we've got through, 7 hours of the meeting before the Brexit vote. Yes, let me tell you that these procedures were a lot more successful than Brexit.